This is a video for the GIE author interview series for the article Per-Oral Endoscopic Myotomy in Patients with or Without Prior Heller Myotomy, comparing long-term outcomes in a large U.S. single-center cohort.
I'm Stavros Stavropoulos. I'm the senior author of this article, and I'm happy to discuss it for the interview series on behalf of my co-authors. It's a great opportunity to informally discuss this article. I'm Director of Endoscopy at Winthrop University Hospital, where the study was conducted from 2009 to almost the present time. And our study focused specifically on the results of POEM in a challenging subgroup, those patients that had previous Heller myotomy that failed. We looked at our entire database, which at that point was standing at 320 patients. That was about a year and a half ago, and separated the subgroup of Heller patients, which were 46, and compared characteristics and outcomes in those patients compared to the patients that did not have a previous Heller, which were the remaining 272 patients. We feel this is a very important group. Heller is a very effective procedure. Results from published series show efficacy of anywhere between 80 and 95% in the first 5 years. However, what many do not appreciate is that these are the results for Heller published from expert centers that pioneered Heller in the United States in the late 90s. There are very little data on Heller performed in small volume centers. And unfortunately, at the present time, the vast majority of Hellers are performed in centers with very small numbers of Hellers per year, very low volumes. Again, not much data from these centers. There is a study, for example, published a few years back, looking at the period between, I believe, 1999 and 2005. This was still the early days when many of the Hellers may have been concentrated in academic centers and centers with experience, but nevertheless, even on that study, we could see that over 3/4 of Hellers were already being performed in low volume centers with adverse outcomes. The cost was significantly higher. The length of stay was at least twice as long as that of high volume centers. I think that was defined in that study as 20 Hellers per year. And obviously the results from such a study would be even worse now, with Heller having been adopted very widely across the country. So in our state, New York, there are not huge referral centers for Heller over the past 2 decades. So again, the procedure is very distributed, and we get a significant number of failed patients that find their way in our center to consider POEM as a salvage technique. The challenges with this patient are twofold. First, selecting which of these failures have failed for a reason that is amenable to treatment by POEM. That's a significant challenge that requires experience and quite a detailed evaluation, and we'll go through that in our article. The second challenge is the technical challenge of performing a POEM on a patient that has already received a Heller. Obviously, the procedure is being performed posteriorly to avoid the scar tissue from the previous Heller, but again, many may not appreciate these patients tend to have much longer disease and previous manipulations apart from the Heller than a group that has not received a Heller. In our study, for example, we found that almost half of the prior Heller patients had advanced end-stage disease, compared to about 12% on the remaining group that did not have a prior Heller. Similarly, 2 or 3 times more patients in the Heller group had previous Botox or balloon dilation compared to the remainder of the group. So these are challenging patients because of long-standing disease and sigmoid end-stage esophagus. These are conditions that make POEM more difficult because of fibrosis of the wall of the esophagus, and a sigmoid course that makes tunneling and completion of the myotomy more difficult. This is addressed also in our video, where we show one of the most challenging post-Heller poems we have performed, and discusses the issues with losing orientation in a sigmoid esophagus, fibrosis from the previous surgery or from chronic stasis, etc. So in the article, we focus on those 2 points. We focus on proper patient selection. We have a flowchart that indicates that we rejected almost 1/4 of the patients referred to us for salvage poem after Heller. The cause of Heller failure is very important to ascertain. The most common cause, again, because Heller is not performed in low volume centers, is an inadequate myotomy, and their poem can be incredibly helpful as a salvage technique. However, the other causes of failure, there could be a tight fundoplication. Fortunately, this is a very rare cause, but that would require a revisional surgery rather than a poem. Other more common causes would be reflux. Again, it may not be appreciated that many of the patients presenting with dysphagia after a Heller may have dysphagia as a symptom of sequela of reflux rather than a tight sphincter or an inadequate myotomy. In these patients, a careful endoscopy and maybe even pH study could confirm that there is severe erosive esophagitis and edema, or even a peptic stricture causing the symptoms. Obviously, these patients are not good candidates for POEM as a salvage treatment. Another common cause, especially we looked at in our study in patients that had early Heller failure, defined as less than 2 years after the Heller, versus late Heller failure. Why? Because if some patient had a very good, successful response to Heller initially, but say 10 years later developed symptoms, this is unlikely to be caused by an inadequate initial surgery. The cause may often be progression of disease. Even with appropriate treatment, achalasia is a chronic disease that progresses. If an esophagus goes from a diameter of 4 centimeters to 6 or 8 as the disease progresses, obviously the amount of hydrostatic pressure you can generate drops by the square factor because it's dependent on the cross-sectional area. And therefore, an orifice that may have been adequate for an esophagus that was a straight 4 centimeter esophagus may not be as adequate in an esophagus that is now 6 or 8 centimeters. In those patients, decision regarding POEM has to be individualized based on endoscopic data, endoflip data that show diameter and distensibility, and even HRM showing how much residual pressure exists in those patients. In our comparison of the early failures to the late failures, we could clearly show a much higher residual LES pressure in the early Heller failures, implying a very significant factor being an inadequate myotomy by the surgeon, versus a relatively low pressure in the later failures. The order was somewhere between 34 millimeters of mercury in the early failures versus 15 millimeters mercury LES pressure in the late failures. Nevertheless, those late failures, which were about half our patients that we selected for POEM, did very well. The overall success rate was in the Heller group was 95%, and not much different between the early and the late patients, again because of proper patient selection on our part based on our extensive experience. And the success was also similar to the non-prior Heller group, with success over 90% for both groups at an average follow-up of 23 months and 28 months respectively. Adverse events also not much different, mean length of stay. Again, that's based on proper patient selection and also on our extensive experience. As I said, these are technically challenging POEMs, and therefore our first POEM on a post-Heller patient occurred as the number 37 procedure in our series. We have already published data showing that competence in our series was achieved on the 40th case based on QSUM analysis. So it was right at that point where we introduced POEM in post-Heller patients, and hence we believe the good technical results and long-term outcomes. So these two issues, as I said, were discussed very carefully. We have two examples of patients who had a failure because of GERD or disease progression, where POEM was not appropriate, and we also offer a trick to overcome the technical challenges of how to put a marker on the scope that achieves not losing orientation during tunnel formation, and we discuss extensively these two challenges presented by these post-Heller patients. And this is what I would like to highlight from our series, and thank you for listening.